Today I'm going to discuss intensive suit therapy for presentation number 2. History and development of suit therapy. The original suit therapy was termed the Adeli suit, and it was developed in 1991 and was known as the Adeli 92. This suit was developed in Russia. The suit is an adaptation of what astronauts wore while inside a space station in order to prevent the effects of weightlessness on bone density and muscle mass. The suit was named the Penguin suit and was created in 1971 for the Russian space program in order to offset those negative effects of zero gravity. The Adeli suit was developed by Professor Arnold Barer from Zaveda Corporation and 2 Russian physical therapists. Suit design. The suit is comprised of a vest, shorts, knee pads, and specially designed shoes. Pieces of the suit are connected by hooks, rings, and elastic bands that are adjusted in order to provide pressure and to support the muscle groups and joints. The suit is reported to provide a vertical load of anywhere between 30 and 80 pounds of pressure, giving proprioceptive input. The bungee-like cords are adjusted by physical therapists to mimic normal flexor and extensor patterns of major muscle groups in an attempt to reposition limbs to correct abnormal development. So this slide shows 3 pictures of children undergoing suit therapy. The top left shows a child working on some sitting activities. She's wearing the vest, shorts, and knee pads, as well as the bungee cords are attached. The top right picture shows a child in the suit working on gait training, and the bottom picture shows a child in the universal exercise cage. History and development of suit therapy. In 2002, physical therapists Richard and Isabella Koshbini brought a similar technology to the United States. They changed the terminology to TheraSuit and patented it through the FDA. There are current training sessions that are ongoing here in the United States and abroad, a majority of those being in Brazil. Principles of use. The Russian physical therapist Semenova, who created the original suit, the Adeli, coined the term dynamic proprioceptive correction. The suit, for her work, would reduce the pathological synergies, restore normal muscular synergies, and apply load to anti-gravity musculature that would normalize the afferent vestibulo-proprioceptive input. Her work is based on 3 principles: the effect of the suit, which is working against resistance loads, increased proprioception and realignment, intensive daily physical therapy for 1 month, and active motor participation by the participant. Principles of use. According to the TheraSuit method, the focus is similar as of that from the Adeli, which is to align the body as close to normal, promote development of both fine and gross motor skills, and to normalize gait patterns. Description of activities. From the original Russian protocol, the Adeli, the protocol included massage before the suit is fitted, and oftentimes with hot packs applied, passive stretching of all limb muscles, application of the suit by placing the body into proper alignment and restricting limb positions, thereby loading the patient's musculature. And lastly, rigorous exercises in the suit. The children would be given an individualized program based on functional weight bearing, gross motor activities, primarily related to locomotion. In comparison to the Adeli suit, the TheraSuit method is similar. However, the intensity is increased to 4 hours a day, 5 days a week, for 3 weeks by occupational and physical therapists who have received the specialized training in this intervention. The following are contraindications for suit therapy use, and this was a combination from the studies that I looked at. They include hip subluxation, severe scoliosis, intrathecal baclofen pump placement, uncontrolled seizures, behavior or psychiatric disorders, having a high degree of spasticity, hydrocephalus and progressive encephalopathies and myopathies, any history of selective dorsal rhizotomy or Botox within the last 3 months, autism or attention deficit, and the last is any orthopedic surgery within the past year. The first study that I'm going to discuss was by Barheim et al. And was one of the first suit therapy research studies. And the study compared the efficacy of the Adeli suit treatment, which was known as AST, with neurodevelopmental treatment in children with cerebral palsy. Specifically, the researchers wanted to investigate the effects of AST on gross motor function and energy cost, which was quantified by mechanical efficiency. So their study design looked at 24 children with a GMF-CS level between 2 and 4, and the subjects were matched by age and functional status and then randomly assigned to either the Adeli suit versus the NDT group. In the Adeli suit group, there was 12 subjects, 8 males, 4 females, with a mean age of 8.3, 6 with spastic ataxic diplegia, 1 with triplegia, and 5 with spastic or mixed quadriplegia. The NDT group also had 12 subjects, 9 males and 3 females, with a mean age of 8.1 years. 5 had spastic diplegia and 7 had mixed spastic quadriplegia. Both groups were treated for 4 weeks at an intensity of 2 hours a day, 5 days a week, providing 20 sessions of intervention. The goal was to compare treatments. The GMFM-66 and Mechanical Efficiency Index during stair climbing were used as their measurement outcomes. They did this at baseline, 1 month after treatment, and 9 months after baseline. The protocol that they followed was the original Russian protocol, which included massage before donning the suit, passive stretching of all extremities, making sure that they applied the suit to provide optimal postural alignment, and restricting limb positions, which would in essence load the muscles. And then once they were in the suit, this was followed by rigorous exercises, which included walking on levels in various terrains, standing from sitting, playing with a ball in either standing, jumping on a trampoline, or climbing stairs and ladders. Russian physical therapists who were deemed experts in the Adeli suit application were the ones who actually treated the children in the experimental group. So looking at the measurement tools, the researchers used the GMFM-66, which is used to evaluate changes in gross motor function in children with CP in 5 dimensions: rolling and lying, crawling and kneeling, sitting, standing, and walking, jump, and run activities. They also looked at mechanical efficiency, which they chose to do stair climbing in order to circumvent the difficulties that might occur achieving a steady metabolic state with those children who have gait impairments already. This was accomplished by the use of monitoring heart rate, as heart rate is related to oxygen uptake during exercise and then can be used to estimate the actual metabolic energy cost. The child was asked to walk 4 to 5 minutes up and down the stairs, which were the dynamic stair trainer, and they were allowed to choose a pace that was comfortable for them, and they also could use a handrail if needed. So the results showed that there was actually significant improvement in the GMFM-66 scores after 1 month in both groups. This change from baseline was sustained for 9 months after treatment. The NDT group showed significant difference between baseline and 10-month scores. the Adeli suit group showed significant scores between baseline and 1-month scores. So looking at this slide, you can see these are graphs that are actually within the study. So the one on the left shows the change in gross motor function, and the one on the right shows changes in mechanical efficiency index. And all of them looked at changes from baseline to 1 month to 10 months. So looking at the left, the top graph actually shows those percent changes in the highest scoring GMFM subjects. The middle one shows the lowest scoring GMFM subjects, and then the bottom shows the mean. And if you look at that last one, which shows the mean, you can see that the NDT group continue to show an increase in GMFM scores, where the Adeli suit showed an increase originally at 1 month, but then dropped slightly at 10 months from baseline. Looking at those graphs on the right in mechanical efficiency, again, the top one shows the highest scoring GMFM subjects, middle shows the lowest, and then the last one shows the mean. And so what was kind of interesting about the top graph is that the NDT group showed really no significant change in mechanical efficiency, but the Adeli suit group actually did show a significant change, but only with those who were in the highest scoring GMFM subjects. So what is the bottom line? The researchers' goals was to investigate whether children with cerebral palsy who receive physical therapy with original intensive Adeli suit therapy approach would have greater improvement in motor function and mechanical efficiency than children who receive therapy with an NDT approach at the same intensity. The results suggested that mechanical efficiency might actually improve with Adeli suit therapy, particularly with children who score at the higher level of motor function. The motor function did not demonstrate any significant change. Commentary from Ann Turner reported that in order to truly determine the efficacy of the suit, both groups should actually receive the same treatment. The actual effects of the suit would then be more evident. Additionally, she reported that it would have been helpful if the actual types of activities were listed. For example, sample of therapy activities. And further research actually did do that. And lastly, she questioned if ambulation would have been a better measure to assess energy costs than stair climbing, as children in level 4 automatically have a difficult time with this activity. So the next article, the next study that I'm going to look at was by Bales et al., which was the effect of suit wear during an intensive therapy program in children with cerebral palsy. So the objective in this study was to examine the effects of suit wear during an intensive therapy program on motor function among children with cerebral palsy. The study also looked at parent satisfaction with the intensive therapy program. The study design was a randomized controlled single-blinded study. 20 children were involved, ages 3 to 8, with a GMF-CS classification of 3. Both groups received physical therapy intervention for 4 hours a day, 5 days a week, over a 3-week period. Occupational and physical therapists who provided the therapy were trained in the TheraSuit method. The control group wore a control suit but did not actually have the elastic bungee cords attached. Each child's intervention was individualized to the goal of achieving the next functional activity level. Outcome measures were administered before and after at 4 and 9 weeks respectively, with the GMFM 66 and the PD functional skills mobility. So looking at the measurement tools, the researchers used the PD, Pediatric Evaluation of Disability Inventory. This is a 197-item parental report questionnaire that measures functional skills and caregiver assistance across domains of self-care, mobility, social functioning for infants and children from 6 months to 7.5 years. As mentioned previously, the GMFM 66 is a valid and reliable assessment tool that looks at motor skills with children with CP, and it is sensitive to change over time. The researchers also used a parent satisfaction questionnaire that they developed. It was non-standardized, investigator-developed, that was given to parents at the end of the last session. The questionnaire rated the comfort level of the child during the program and asked parents' thoughts on if the program was actually helpful and if they would enroll again. So looking at this chart from this study, the outcome measure was listed. So they looked at the GMFM between each group, between the experimental and control group, and then horizontally the scores were looked at from baseline to 4 weeks to 9 weeks. And essentially, if you kind of glance through those, you can see that there was actually no significant difference between the two groups and between baseline to 4 weeks to 9 weeks. So the results showed actually that there was no significant differences between groups. The strengths of this study included that the subjects were randomized, all children were at similar functional level, and age ranges were narrow. The limitations were that it was a very small sample size, and there was actually lack of blinding of families and treating therapists, and the outcome measures did not actually measure gait. So this lack of blinding is something that was mentioned because the parents and the therapists were actually aware that it was a control suit, just because the parents were aware of what the suit therapy actually involved, and obviously the therapists did as well. So the clinical bottom line is that this study did not actually prove statistical evidence that the use of the TheraSuit will improve motor function during intensive therapy programs, more than an intensive program wearing a control suit with children with cerebral palsy that were classified under the GMFCS Level 3. The last study I'm going to discuss today is a study that was done by the same researcher, Bales et al., and it looks at changes in 2 children with cerebral palsy after intensive suit therapy, a case report. So the purpose was to investigate the effects of intensive suit therapy on gait, functional skills, caregiver assistance, and gross motor ability on children with cerebral palsy. The study design looked at 2 children with spastic diplegia at a GMFCS Level 3 who participated in TheraSuit therapy for 4 hours a day, 5 days a week, for 3 weeks. All of the activities were administered in the same sequence daily. Participant 1, who was 8 years old, focused on achieving 2 main functional goals. One was ambulation without loft-strand crutches for community distances and greater independence in self-care skills. Participant 2, who was 7, focused on 2 functional goals: transitions from the floor to standing and ambulating without single-point canes for short distances. So continuing on with the research from Bales et al., Table 2 shows sequence and description of TheraSuit activities. So briefly to list out the activities, they began with a hot pack and massage to all extremities. Then they were placed inside the universal exercise unit for lower extremity strengthening and range of motion using some pulleys. After that, they would have a rest break, toileting, actually don the suit with the bungees attached, and then work on strengthening activities with a Swiss ball, bolsters, plinths, and benches for the total time listed there. They'd get another rest break and then go back to using the pulleys, focus on sensory motor activities after that, fine motor activities, have another brief rest break, and then they completed their activities with balance and coordination activities in the Universal Exercise Unit. And then lastly, they would work on gross motor functional skills, including standing, transitions, and progression of ambulation. So continuing on with the research from Bales et al., the measurement tools, the researchers looked at performance on the PD and on the GMFM-66, but only with domains D and E, as well as gait analysis. Domain D includes standing, and E includes walking, running, and jumping. Pre-assessments were taken 3 days prior to initiation of the study for participant 1 and 10 days for participant 2. Scores were compared between pre-test and post-test. For gait analysis, walking speed, cadence, limb support time, step length, and joint motion of the hip, knee, ankle, trunk, and pelvis were compared. There was minor changes seen on dimensions D and E of the GMFM and PD. Both participants actually demonstrated a decrease in functional skills and caregiver assessment self-care, as well as small decreases on some domains of the PD. Gait analysis showed increased self-selected gait velocity and increased cadence. So clinical bottom line on this study. Both participants showed minimal gains in some areas and actually declined in others. Gait movement patterns may have changed positively. However, changes were small and have been reported in studies that were associated with muscle strengthening programs. The strengths of this study include the fact that gait analysis was utilized. However, limitations include a small sample size. This just lists a YouTube video of a child that is receiving TheraSuit therapy, including the Universal Exercise Unit. So when you have time, you can watch that. It's pretty interesting. So these are my references listed for the studies that I looked at for this presentation. I think a physical therapist who is considering utilizing the suit therapy for a child should definitely look into these studies and make an informed decision as a